To go.
All right. So hi everyone, I'm Christina. I'm one of the second years if you don't know me. Interested in infectious disease, specifically epidemiology, outbreaks, biodefense, that kind of stuff. So kind of right up my alley. But I wanted to talk today about Remdesivir and do a journal club about one of the many studies that have come out about Remdesivir. Full disclosure, this is my first journal club, so if you have any feedback for me later, just let me know. But let's get started. I hope you guys enjoyed it if you had a chance to read the article. If not, we'll go through a lot of the highlights together. So this was the article. It was Remdesivir in adults with severe COVID-19. It was a randomized, double-blind, placebo-controlled trial done in multiple centers in the heart of the outbreak in China. Published in the Lancet on the 29th of April. So sadly, the 29th of April makes it one of the older articles. There are a few more that have come out since then. So we'll go over that in just a little bit, but this is a link in case you didn't have it already. But basically what they did was they took eligible patients, they kind of randomly assigned them into a 2-to-1 ratio to either get remdesivir infusion or placebo infusion. The dosing of remdesivir is here on listed. Usually the dosing that they've been using in multiple trials in the past, 200 on day 1, followed by 100 on days 5 or 2 to 10 as a single dose infusion. They have done a study to see if they've had, if you can do it up to 5 days or 10 days. I've seen a lot of studies kind of just do the full 10 if the patients aren't improving. But I believe that study showed that there was no difference in outcomes from 5 and 10. They had an N of 237 with 158 in the remdesivir group and 79 in the placebo group, with a primary endpoint of time to clinical improvement up to day 28. And they defined clinical improvement as a decline of 2 levels on a 6-point ordinal scale, which we'll go over in just a second. And the analysis that they used was intention to treat. So just some background information, remdesivir, it is an antiviral, was developed initially during the Ebola outbreak. And unfortunately, the Ebola outbreak back in, I believe, 2016 or 2017 resolved before they were able to get to human trials. Then they had another outbreak in 2018 and were able to do a trial at that point. So they do have a safety profile on that from that outbreak, but they didn't really show any benefit in Ebola. And so that medication was no longer used. It is an RNA-dependent RNA polymerase inhibitor, kind of disrupts the viral replication by acting as a nucleoside analog specifically for adenosine. So it inserts into the viral RNA and stops replication. Lucky for us, our system kind of can figure out what remdesivir is and that it's different and can kind of correct all those errors so it doesn't kill us, but has been shown to kind of lead to improvements in vitro studies. And so that's why we're here today discussing this. So kind of taking a look at how they kind of allocated everything. What do you guys think about this unequal allocation? Why do you think they did that initially?
Limited in quantity supply. Remdesivir.
Okay. So definitely one of the reasons that they can do unequal allocation is if you have, if you're trying to see or use it more and have a limited population and you want to get as much exposure as you can to the medication. Yeah, more safety data. Absolutely. So they can increase that as well. It also sometimes I've seen people use it as a way to improve recruitment, saying that you're more likely to get it, so more likely to get the medication. People kind of sign up for the study a little bit more. But kind of looking over this, does an unequal allocation have any impact on like the study or the outcomes or any aspect of the study? So one of the things that an unequal allocation leads to is a decrease in your power. So whenever you have equal allocation, you can do power calculations to determine what your goal sample size will be. Whenever you do unequal allocation, that actually kind of throws a wrench in those calculations, and your power drops. So you do need to increase your sample sizes in order to maintain a power of 80%. So it kind of can impact that a little bit. There have been other things in this study in particular that have impacted the power, but we will get to that in a little bit. My last question on this slide before we move on is just kind of the intention to treat. What is the difference between intention to treat and like per protocol? Why would we choose one over the other? So intention to treat, the analysis that they used, kind of going over that real quick, is more of an analysis of once you're randomized, you're analyzed. So it's a good reflection of kind of how things are in reality. So if a patient is signed up to get a drug or a medication in a study, but they don't get it for whatever reason, either we don't order it or they get discharged before then or something like that, or it just doesn't get administered, they're still considered in that treatment group as a way to kind of see how adherence can impact a person's or the effect of the drug. So it helps a lot with kind of minimizing false negative or false positives and type 1 error. And so whenever you have that, it does increase your proneness to type 2 error in situations of poor adherence. Per protocol is a little bit different. They've used both. The per protocol was more for the secondary outcomes, but it includes only study participants who actually completed the study without any variation from the protocol. So they were exactly per protocol. And normally, whenever we have non-inferiority trials, we report both, so you can kind of see what the effect of adherence is on the study. All right. So here I have the 6-point ordinal scale that they were using, anywhere from 6 being death, which there was like one person in the remdesivir that started off with a baseline of 6, all the way down to being discharged or having reached the criteria for discharge, which are having no fevers, having less than 24 breaths per minute on room air, doing well, and then relief of cough, at least for 72 hours. From that point, they were able to be considered dischargeable. And then anything in between, either ECMO, mechanical ventilation, needing a lot of oxygen, not needing a lot of oxygen, and then needing no oxygen. So the primary endpoint was time to being able to improve on this ordinal scale, like diminish 2 points. So what do you guys think about that as a primary outcome, or like the ordinal scale in general? Why would we use an ordinal scale? Yeah, come back from death.
I mean, in some ways it kind of makes sense just because people obviously have like very fluctuating like oxygen requirements. I think that's like the biggest thing um that like these patients require. And so if somebody's going from like 2 to 6 liters, from one day to the next and then back down, like how do you really quantify something that might change, hour to hour? So I think it helps you categorize the data in that way. Um, but that being said, these are also like pretty broad categories, like oxygen, some oxygen, tons of oxygen, like ECMO, like those are pretty pretty huge steps. So I mean, a step down in one of those, I mean, is like a fairly significant clinical change. So I guess in some ways I can see why that would be useful.
Hmm. Yeah, I agree. And I agree with Sneha's comment as well. Standardizing data, there have been some talks that they're using these ordinal scales in a lot of these studies as a way to kind of standardize for meta-analysis as well. My question would be, if you had a patient go from not from 6, but maybe from 5 to 3 versus 3 to 1, does that would you consider those equal as far as like we've reached our time to improvement? I guess that's Sneha shaking her head.
Yeah, I agree with you. I mean, it seems like that's very different to be still on high flow, meaning like at least at our hospital, you'd still be in step down versus somebody who wasn't step down and is now discharged. Definitely has like a bigger impact for like healthcare, like implications, that we're trying to make decisions about at like a larger scale.
Mhm. All right. So any questions about the ordinal scale? Good. So they have a bunch of other study or secondary outcomes that they were taking a look at. They were looking at exactly where you were on the ordinal scale at certain time points throughout the 28 days, looking at all-cause mortality, how often people were on like vents or just regular oxygen. They were looking at the RNA detection itself and the quant levels, as well as safety outcomes. They did do some safety, but it wasn't powered to be a safety outcome thing. We do have some safety data, but kind of adding to that. So those were the secondary outcomes. And then here's our conclusion criteria. So they included patients who were at least 18 years of age, had the SARS-CoV-2 positive on PCR and pneumonia on chest imaging. They also had some sort of oxygen requirement, either an O2 sat of less than 94% on room air or P to F ratio of 300 or less. And then the symptoms had to be present for at least 12 days or less, not any more than that. They excluded pregnant and breastfeeding women, hepatic cirrhosis or having an elevated transaminitis, any sort of renal impairment or requiring renal replacement therapy. If they were going to be transferred to a non-study hospital, they didn't want to include them. And then if they were previously enrolled in a study on medications in the last 30 days. However, they didn't really say that you could not be on anything additional. So you were able to get lopinavir, ritonavir, you were able to get interferon, antibiotics, steroids at the discretion of the provider. So what do you guys think about these inclusion criteria?
I mean, the inclusion criteria seem very reasonable. The exclusion ones, I mean, the only ones that I think are somewhat concerning are like the in terms of generalizability, like the cirrhosis and ESRD. Like obviously that's a ton of people, and we know those people are at higher risk. So that makes it a little bit less generalizable. And then just we're probably gonna talk about this here later, but like the use of other treatments, the lack of a standard of care here I feel like is somewhat problematic because we're comparing a specified treatment group to a very heterogeneous group of like placebo. Um, and so I don't love that just because those people are also getting experimental treatments with unknown effects. So like it's not the best comparison. I think it would have been better if they just did like a true single placebo or everybody got steroids or nobody got steroids, just the same.
Yeah. So the fact that we're having additional experimental medications or how many people are getting steroids versus not steroids definitely can kind of make the data and the results confusing. I agree. All right. So let's take a look at our study population. So lots of stuff here. If you have the paper with you, might be easier to read. But so kind of breaking it down a little bit. Generally, the placebo group had more men than women. And then the big things that I kind of wanted to point out was just the other things that they were receiving, kind of what Danny was talking about. So looking at their baseline, receiving lopinavir, ritonavir, looking at the baseline of how many people were getting steroids, was not extremely high, but it looked like it may have increased later. What do you guys think about this stuff? Do we feel like we have a good comparison here? I know that you kind of have to look at the percentages because we do have unequal allocation. So the remdesivir group does have a higher population. Do you guys feel like that it's kind of an equal representation in both groups?
Patient getting remdesivir are definitely have more comorbidities, like hypertension, diabetes. Like they're almost doubled, at least doubled. This is randomized.
Yep. So it was randomized. They kind of did like a stratification like randomization based on baseline oxygen requirements, but from like otherwise they were randomized.
And even if you look at like their ordinal scale, the experimental group seems to be higher, like more.
That one at 6.
Interesting.
I mean, overall, it looks okay, given like the low end, and it's not perfect, obviously. And I don't see if they put p-values on here for some of them. But otherwise, I mean, it doesn't look the worst. They overall look decently equal at first glance.
Yeah, I think that they're generally pretty equal. The thing that threw me off whenever I first saw it was looking at the actual numbers. I was like panicking because I was like, oh my gosh, there's so many people in the remdesivir group that are like in level 3 on the ordinal scale, but like forgot to look at the percentages. But yeah, it seems like level 3 that was the requiring some supplemental oxygen, but not incredibly high amounts. And level 4 were kind of our big starting points. So we were dealing with people with an oxygen requirement that would be admitted. We're not dealing with these outpatients. There was an article recently on triple therapy that was dealing with a lot of patients who did not require oxygen and more of like an outpatient situation in the hospital. But we were dealing with hospital patients with some comorbidities, and generally we're about the same. Even kind of looking at the antibiotics and steroid treatment during the study, it looks like they were not favoring one over the other. We weren't seeing the placebo group getting a lot of steroids and the other group not. So, all right. So this is just kind of our the breakdown of how they were assigned and how many people ended up completing this study. So they started with 158 in the remdesivir group and 79 in the placebo group. 3 patients on the remdesivir side didn't start the study treatment, but were included in the intention to treat. And then 5 received remdesivir less than 5 days, so they were not considered, or they had to be added back into the safety population. On the placebo side, only 1 person withdrew consent, so they ended up with 78 in their intention to treat. And then they had 2 who received placebo for less than 5 days. So they were not included in the protocol. Based on these numbers, what do you guys think? And kind of knowing what you know about intention to treat and per protocol, do you think that the intention to treat analysis had a huge impact on what we see here?
Probably not a huge difference. I mean, they only lost 8 total people in the remdesivir group and like 3 in the placebo group. So like, I mean, not a huge number.
Yeah. So this is probably pretty representative of the actual outcomes. We're not really worried that adherence is going to play a huge impact on the results. All right. So speaking of results, what they found, they wanted to enroll 453 patients, only on the based on 80% power and about 2.5% significance level. They were only able to enroll 255 patients, of which 237 were eligible. And the amazing thing is because they just ran out of patients who had coronavirus. They had such good public health interventions, they just didn't have any more patients in the hospital, or so they reported. But it's a great win for public health. The time to clinical improvement was not statistically significant to that of the control group. And they, although not statistically significant, they did make a comment that they had a shorter, numerically faster time to clinical improvement in the remdesivir group, 18 versus 23 days. So kind of looking at this, they quoted a power of 58% on their study based on how many patients they were actually able to enroll in the unequal allocation. What does 58% power mean to you? Yeah, not great. So kind of going over just power in general. So power is the probability of a study to be able to detect a difference if it actually is there. So it's kind of related to the type 2 errors, which kind of are related to the false negatives. So what it's based on the primary outcome. So if you have, with the FDA, they recommend at least 80%. So in a study that is powered to be 80%, there is an 80% chance that if there is a difference, that you'll be able to reject the null hypothesis, and a 20% chance that you won't, and that you'll just miss it. Whenever you start getting into lower powers, such as like 58%, what you're saying is that there's 58% chance that if there is a difference, we are going to be able to find it, and a 42% chance, if I'm doing my math correctly, that you will not be able to find it. So it's slightly better than 50-50, that we would be able to see a difference if it was there. So whenever we have a study that comes out that's showing no difference and we're accepting the null hypothesis, with such a low power, it's kind of hard to say for sure that that's what's going on. Does that make sense? So for this study, we did have such a low power. We're not sure if remdesivir really does anything, but what they did see was that there was a numerically faster time to clinical improvement. What do we think of this? Is this something that we can use, such as like like in a Tamiflu situation where we can give it to a patient to improve them faster. Does this have any utility based on these results?
I feel like it's one of those things like you could certainly consider trying it, after like discussing risks and benefits with a patient. Because I feel like we're still kind of maybe we're getting out of it now. We have better studies to draw better conclusions on. But I mean, in the early, times, people are just looking for anything. Um, and I don't think this study showed in the limited safety data, which it obviously wasn't primarily dedicated to, that like it was relatively well tolerated. I forget whatever it was, like 12% or something had some sort of adverse reactions. Um, but I think, a lot of people would still consider this just on this trial alone, would consider trying it, and would certainly try it in the context of another clinical trial, hopefully with a larger N. So I think it's like, you definitely aren't going to make any promises to your patient, but if it's like physically available at your institution, I think it'd be worthwhile to try based on this study, with the limited data that we have. That's kind of how I would interpret this.
Yeah, I agree with Danny too. I feel like it mandates like another clinical trial, but I think there's definitely some improvement that's needed. I think the comorbidity should be more equally distributed, and I also think that the ordinal scale could be expanded. So those would be my two things for the next study.
Okay. Yeah, absolutely. Definitely agree with both of you guys that this is a medication that we definitely need more information on, but the results that we have right now are not saying that it would be totally out of the ballpark to use it on a patient if you had it available. I included the results here. They didn't really have anything that was statistically significant, like we said, but kind of going through it, that they had a faster time just in general, which we kind of already said. And then our famous Kaplan-Meier curve, which really didn't show a whole lot based on our results. But lucky for you guys, there are so many remdesivir trials going on right now. I have this included in the PowerPoint. I don't know if Sydney's going to share this, but I went through a bunch of trials kind of leading up to this point and then past this point. So this is the first one that came out, the compassionate use trial. That basically didn't have a placebo group. They were just trying it, and they only had an N of 53. Kind of difficult to interpret the safety because a lot of their adverse events were part of the natural clinical course of the disease. And they didn't really do any adjustment for multiple comparisons, so it was really hard to interpret their data. But this was kind of the first step in the COVID remdesivir trials. The reason COVID has been so, remdesivir has been so popular, they've been showing that it did work in macaques. They've seen that this medication, I really enjoyed this one because it was actually an in vitro study done in 2017 against SARS-CoV, MERS-CoV, as well as some pre-pandemic strains. So that they were basically preparing for now and testing remdesivir to see if it was going to have any impact. And they showed that it might have some impact. So that was exciting. This is one of the reasons that remdesivir and hydroxychloroquine and chloroquine have been all throughout the news, because there was a study that showed that they probably have the best safety profile, the lowest having cytotoxicity without having a whole lot of adverse effects and being able to reach a level of the drug. And so those have been studied a lot recently. And then finally, this is the fancy new trial that came out like 2 days after I finished my presentation. So it's the world is changing very fast. But this study was basically a multi-center adaptive randomized blinded controlled trial that was performed throughout a lot of different centers. I believe there was some in the United States, Canada, and I believe China. I'm sorry, I have it here in one of my things, but so basically they were showing that there was a improvement in their like faster time to recovery than those who received placebo. This was that famous trial that they changed their endpoint within a couple of days of publishing, and Dr. Fauci came onto the news and told everybody how great it was. Their initial primary endpoint actually became their main secondary endpoint, and that was the change in the 7-point ordinal scale. So slightly different for you, Sneha, but they expanded it just slightly for you. But they ended up switching that and seeing that it was not quite statistically significant, but this 31% faster time to recovery was statistically significant. So now the FDA is in talks with Gilead, and we're moving on to more trials. So this was the Act 1 trial. We'll be seeing the Act 2 trial soon. But that's kind of all the additional remdesivir stuff on the plate moving forward. So is there just one other question for you guys? Are there any sort of other things that you're excited about as far as treatment of COVID? Anything that you've been reading about or hearing about that you think would be worthwhile to investigate or use if you were given the chance?
I would love to see some more studies on like antibody testing. Just because I think that's like, I don't know, one of the biggest questions. Obviously, we don't have great treatments, but the other thing is just like, ongoing questions about asymptomatic transmission.
Mm-hmm.
And I feel like I looked and there's like a few antibody tests. Like I saw one in California where they just screened blood donors, and it was like I think it was in LA County, and they said like I think it was a pretty low percentage. It was like 4 or 5% had antibodies. But still, I mean, these were presumably like very healthy people who felt well enough to donate blood, um, and were probably younger. And so I think that's like one of the lingering questions, at least until we can get a safe vaccine approved that will facilitate, a return to kind of normal activities. And I don't know, make a lot of us feel better. About taking care of these patients, about kids going back to school, stuff like that. So I feel like antibody testing will be very informative for like the next 6 months, once it becomes available.
Yeah, absolutely. And Sneha, I see you say plasma. There's a couple of trials on that are pretty good too. All right. So here's my references. The last thing I just kind of wanted to give a quick shout out to ID Journal Club. If you are a Twitter person, they do Journal Club pretty much it's supposed to be the first Monday of every month. But since coronavirus has hit, they've been doing it every single Monday. They actually discussed this article back in the beginning of May. They've talked about lopinavir ritonavir in April, the triple therapy there on the 18th, and just this past Monday, actually talked about one of the vaccine trials, one of the recombinant adenovirus vaccines. So it's a good way to kind of stay on top of things, especially in this age where peer review is kind of not as strict right now, just to kind of get the information out. But keeping in mind that anything that you're reading about this, you need to kind of analyze further. But thanks for participating. I really appreciate it. I'm happy that I got to talk about this trial and get to continue to learn more about coronavirus and the treatments.
Thanks, Christina. I think it's important. It's not like that exciting to like, hear about power and stuff, but kind of echoing what Dr. like Joe's was saying with his grand rounds, like just because we're all scared and we don't know that much doesn't mean we need to throw all of evidence-based medicine out the window. And like especially in times like this, you know, I don't know, I feel like in med school we all just kind of hear like, oh yeah, it's published in, this journal, so that's the new guideline. um, Especially in times when these papers are getting pushed out rapidly. just to get the info out there. And some of them are, pre-publication. Some of them are on like the Bio RX IV, whatever. Some of the stuff's not peer reviewed. Like you have to really carefully read it before you start making decisions. So very topical. Very topical.
Yeah, absolutely.
Thank you, Christina. That was excellent. All right. Are we done?
I think so. I don't know how to get out of this.